Welcome, everyone. I'm Dr. Tim Brown. I'm the host for Pharmcast for the community, coming out of the University of Georgia's College of Pharmacy. And today you may actually remember my guest. He was on the first podcast that we did. Dr. Bruce Jones is an infectious disease clinical pharmacist at St. Joseph Candler Health System. He practices in Savannah-wide, citywide antimicrobial management program, which basically means that he takes a large role in what happens with how we look at bacteria, viruses, how to treat them and what to do with them. But also, he's one of ours. He's an adjunct clinical assistant professor at the University of Georgia College of Pharmacy. In his role as infectious disease pharmacist, I wanted to bring you back on and talk about some of the new treatments that we're hearing about, what's going on with regard to the latest stance with medications in terms of managing COVID for those that have been admitted to the hospital. Hi, Dr. Jones. How are you doing?
I'm doing well. Thank you for having me back.
No problem. Thanks for coming on board again. I know you've been busy and things are kind of, I guess, coming to a plateau and people are trying to figure out what to do next. I think one of the things that I had the biggest question about is, what's the update on what it's like managing patients who've been admitted to the hospitals in Savannah and anywhere, I guess? Have things changed any since the last we spoke?
Yeah, I tell you, for us specifically, things are definitely better than when they were last time. I think when we spoke last time, that was about 4 weeks ago, we were seeing 10, 11, 12 days to get these test results back. And that was probably our biggest limitation. And now we're 24, 48 hours. And that's really, I think, changed the game for us. But Ken, as you mentioned, here in Savannah, we're seeing a little bit of a plateau as well.
So when you're talking about getting the test back quickly, these are folks who've been admitted to the hospital with symptoms that look a bit like it's from the virus. And this test is used to tell you if you should proceed as though they're infected or not infected, correct?
Yeah, so when you come in and you have symptoms, you have exposure, you have something that would concern us for COVID-19, we're going to test you, but what that means is we have to put you in isolation. So we put you on a specific floor. You're very much, you're in isolation. Everybody's gowning up, putting on, heavy-duty equipment, face masks to come in. So, being able to turn these results around, number one, it helps kind of get you out of that environment, but it also helps the healthcare workers as well, being able to save that personal protective equipment on somebody who's otherwise doesn't have this.
Oh, I see. So that turnaround's quick, and that's actually quicker than what I'm hearing in the community. So I don't want people to think that their test results are going to come back this quickly if they're getting tested in the community. This is really for people in a hospital right now.
Yeah, I think that's a great point. I'm still hearing, 4 and 5 days in the community. These are kind of just specific to our hospital admitted patients.
No, I understand. I think the other thing that came out recently and that really grabbed my attention was we're learning more and more about the complications. I think we really have sort of struggled a bit, and the media talks a lot about the number of people who've passed away, which is unfortunate, but it really doesn't go back and talk about the number of people who've had complications. What are some of the newer ideas or thoughts that are coming up around this virus in terms of, for those who survive, what complications are we seeing that we're now learning we have to take care of or, I guess, try to prevent?
Yeah, it's kind of interesting what I've had to learn how to deal with. I deal with mainly antibiotics, some antivirals, things like that. And, we're using drugs for rheumatoid arthritis and other disease states. And I'm hearing about all these cardiology issues with your heart. So I'm kind of even going outside of my area expertise. I'll tell you, one of the things I hear more and more about is these patients come in and they have elevated markers that are showing issues possibly with heart disease that could lead to blocks or clots, if you will. So a lot of conversations is when these markers come back elevated, do you start them on the blood thinner? And I think at this point, it's very reasonable to consider doing that. And I think one of the other conversations is, well, how long do you do it? So we're seeing certain patients that are leaving the hospital and continuing on those blood thinners.
That's interesting because I saw a study out from, I can't remember which newspaper it was, but it really talked about strokes and heart attacks and those kinds of things happening in people in their 30s and 40s. And so as this disease evolves, we're finding that there are other complications that are happening and that people are having to, as you point out, maybe leave the hospital on drugs they weren't on at admission just to keep them healthy after they're over the virus. True?
Absolutely. Yeah, I agree.
Yeah, I think the other, and over the weekend I was reading and the FDA's warning on hydroxychloroquine and chloroquine came out, and you and Dr. Chastain really sort of hit this hard in that first podcast of this is not a drug universally used by all. So why is the FDA kind of upset now? What are they concerned about with this particular drug?
Yeah, I tell you, I think the big thing that we've seen, and this was something we were concerned about all along, is these aren't benign drugs, and this is not really their intended purpose. So when we start using them on so many patients, you start seeing some of these side effects that come out. And for us, it was basically risk of heart arrhythmias. So your rhythm of your heart definitely gets off. So we've actually seen that on a few patients. So a few sides of that. One is that you think, well, I'm just taking it for a few days. But a drug like hydroxychloroquine that you mentioned, all right, that stays in the body for over a month. So even if you took it a month ago, you could still see these type of effects. And then, there was a lot of talk early on combining with azithromycin or some of the other drugs we've been using in the hospital. It just makes that effect bigger and bigger and the risk greater.
So, we talked about this in the first podcast, that this drug is something you reserve for when you actually think you might need it, and we're sort of taking a shot in the dark, hoping it'll work. So we're finding out now that probably it is not the miracle drug, as many pharmacists talked about from the very beginning, and that probably it is not the drug everybody should rush out and try to take to prevent the virus. I also have heard, though, that we've sort of taken the focus and moved it around a bit. There's some discussion about HIV medications being used against this virus. What do you know about that? Do those clinical trials or studies have any merit to them so far?
Yeah, if you Google today coronavirus treatment, you'll find probably about 10 to 20 new things that might work. I'm almost scared to find out what some of them may be. I'll tell you specific to what you mentioned with some of those HIV medications. So, early on, they looked at some of the specific ones, and studies have come out since that have basically said probably not of value. And we look at things that have activity in a test tube, if you will, and they work in a lab. Doesn't necessarily mean that they'll translate over to humans. And that was, I think, kind of the case here with this. One thing we always have to remember, whether it's, we mentioned side effects with hydroxychloroquine, but with these, there are people out there that have HIV that desperately rely on these medications. So, to go out and use these in high supply really damages that for people who truly need them. We got to keep that in mind.
So don't use them until we know what's going on, number one. But number two, leave that out there so
Absolutely.
People have access, because these do help suppress the virus for those who are HIV positive. So, all right. So hydroxychloroquine is not the miracle drug. HIV drugs may not be what we're looking for. What are you seeing, or what are you using to manage your patients that are coming in? Like what in particular have you found to have some success, if you will, in sort of managing the virus, for lack of a better term?
Yeah, we've kind of changed our algorithm around a bit, and most hospitals have some kind of algorithm they're using, and they're for the most part very similar. We still are using hydroxychloroquine, but really trying to, very similar to what I mentioned 4 weeks ago, reserving it for those more severe patients. And we have certain criteria we tend to look at. We've tended to move away from azithromycin at this point, unless you also have a pneumonia with your possible coronavirus infection. I would say some of the other things we've looked at zinc. We've kicked that one around a little bit. Vitamin C has been another one that's kind of come and go. We've not used that personally, but I know there's some talk about that. And then for some of our more severe patients, tocilizumab, which goes by the brand name Actemra, convalescent plasma is something that's been talked about, remdesivir. So a lot of different options out there.
So let's go back to the first one. Tell me, that was a really big, long word. Say that again slowly for me.
Which, tocilizumab?
Yeah. What's the brand name of that again?
All right. So Actemra is the brand name. And it goes back to what I said. I was used to working in antibiotics, antivirals, not so much these monoclonal antibodies.
So the Actemra, it's been on the market for a little bit. It has indications. What does it do? What do they think its impact is for the virus? Because obviously it wasn't first put on the market for the virus. So what makes it special right now for its use?
Right, you go and look into this, you're going to find that it was used for rheumatoid arthritis. It's meant to, rheumatoid arthritis as an example is where your immune system attacks your own body. So some of the thought behind this is, I use the word cytokine storm. It sounds like a villain out of a Marvel movie, right? But the thought is when you get this virus, and this is not a new thought, is that you have this almost overload. Your body tends to overreact and attack it. And that's where some of the bad outcomes we've seen from it. So I think where we've looked at this drug is kind of holding back your body from kind of going into that hyperdrive activity.
So it's stopping it's not necessarily fighting the virus. What it's doing is fighting the body from attacking itself then. sort of those complications we talked about, trying to keep them at a lower incidence or maybe minimize them a little bit. Is that fair?
Yeah, I think that's fair. And we've probably used it in a handful of patients at this point. There's some data out there I think that's promising. The biggest problem at this point is we don't have good control trials. We still don't know exactly what dose to even use with it. So we're still kind of shooting from our hip a little bit, but you get some of these severe patients that are as sick as they are, and we're really trying to find something we can do to help them.
And you've seen success with this particular drug, Actimbra?
Not yet, not to be honest with you.
No,
and I mean, I have a very small amount of patients we've given it to, but yeah, that's the honest truth of it is for me, no. I've heard anecdotally others who've used it on a larger amount of patients. With any of these drugs we give, I think sometimes the earlier we can give them, probably the better. But at the same time, it's a risk-benefit balance because with this drug, and you think about what it does, kind of suppressing, holding back your immune system, a lot of bad side effects come from it. So, with what we do in infectious disease, a lot of it is risk-benefit, and this is a very risky drug, so we've got to be careful.
I understand. I think the other one that you said that I've never really heard of before until all this mess. What's it called again? Convalescing plasma? Did I say that correctly?
Yeah, convalescent plasma. That's kind of, it's funny. It sounds like a new kind of term that's come out, but we've had that around since the late 1800s probably. And I think I could kind of best describe it as if you think of active or adaptive and passive immunity. So, there are really two ways you get immunity to something when you're exposed to it. So the first one is vaccines, which we think of. And the other one is you get a disease like COVID-19, you survive from it, and then a few weeks later you develop antibodies from it. And it's kind of your body's way of saying, hey, look, I've seen this before, I fought this before, I kind of know how to fight it. And then so what we're doing with this convalescent plasma is we're taking those patients who have just done just that, they've survived it. We're taking plasma from them, and we're basically sending that plasma into somebody else, and that's where the passive immunity comes in. So you can give those antibodies to another individual.
Interesting. And I guess with that one, that's come up, but there's been some discussion this weekend from the World Health Organization with regard, do antibodies really translate to immunity? So this is, I'm sure, being looked at and studied using this convalescent plasma technique. Is that true? Yeah, there are a lot of studies ongoing. So, it's something very promising. Still don't have the results with it. It was actually most recently being looked at in Ebola and didn't have the most amazing results there. However, we've seen that with the H1N1 flu that we saw a few years ago, as well as the last coronavirus that we called SARS, we saw good activity with that. So I think there is hope with it, but still nothing proven yet. I understand. And I think the last drug that you mentioned, what was it called again? The remdesivir, is that correct?
Remdesivir, yes.
Now that is an antiviral.
So remdesivir, right? Yeah. So at least this one's an antiviral we can talk about.
So when I say antiviral, and I'm sure you're going to take this to a technical term, but basically, antiviral means it's specifically going after the virus. It's attacking the virus. Where the others we've talked about are kind of giving the body immunity or stopping a complication. This one is the one I've been hearing the most about that actually is going to go in and really truthfully, proverbially kick the virus's butt. Is that the whole point?
Yeah, with a lot of this stuff, we're either stopping the effects the virus has on the body or kind of helping the body to fight it. This is one that truly goes in and attacks it, as you mentioned. So being able to stop the spread of it, if you will.
And how is that impacting? Do we know? Because that's not on the market yet, right? It's in clinical trials?
Correct. Yeah, a company called Gilead has the drug. Actually, the only way you could get it as of recent was either through a clinical trial or by something called compassionate use. And that's where you have a patient, they have a disease, and they've really exhausted any other option. So we actually never were able to use it. We had some patients that otherwise would qualify, but the problem is with a widespread pandemic like this, they were very overrun in their compassionate use program, and it's actually put on hold. So, unless you're going through a clinical trial or they've kind of made exceptions if you are pregnant or under the age of 18, that's kind of the only way you're getting that drug at this point.
Got it. And how does this one look? I mean, in terms of what you've seen, I know the trials are limited, but in your professional opinion, does it look like it really does fight the virus well?
Man, hard to tell. If New England Journal of Medicine published an article here in the past week, and I read that article, and I feel like I walked away knowing about as much as I walked in with. There were some markers that looked hopeful, but until you compare it against people that did not get the drug, it's going to be really hard to tell a whole lot. And, from what I keep hearing, as of today, and what's today, April 27th, could be any day in the next week, 2 at the most, we should get the first of these trials to come out. So I think there's 7 trials currently ongoing. The first of them should have results. So hopefully by the time we get this podcast out and we get this out and going, we'll have some results to talk about.
That's good news. I think, Dr. Jones, to your point about that, many people have been talking about, sequestering, quarantining, shelter in place, whatever terminology you want to use. I don't think many of them realize that was sort of done to sort of keep the healthcare system from being overwhelmed by the number of people, not necessarily to make the virus go away. If we buy more time, if we shelter in place, does that give us more time to figure out from the clinical trials if drugs like remdesivir is going to be effective? So if this, excuse this term, surges again, we kind of do have a drug that's been tested versus this time around, we didn't really have a lot of clinical trials. So is that fair to say that quarantining, shelter in place may help us in the end with regard to fighting this next wave that's going to occur?
Yeah, I think as anybody that's seen, with every week that goes by and almost every day that goes by, we learn more about this virus, and we learn more about the things that are out there to treat it. Sometimes for the good, sometimes for the bad. When we spoke 4 weeks ago, people were being treated very differently than they are now, and that's just from some of the things that have come out that have actually been negative or bad. So whether it's good or bad, the longer we're able to hold off the worst of this and get more data on these drugs, the more beneficial it is.
I understand. I want to say thank you for your time, Dr. Jones. We've talked a bit about the newer therapies that are coming out. If you had to leave the community with 3 pearls of what we've talked about today, what would you tell them?
3 pearls. I think that one that I would definitely hit up on, and I'll keep it very simple, is that there are no drugs currently indicated to treat this virus. You're going to go out there. There are a lot of people out there that are going to talk about a lot of different options, but there's currently still nothing proven to treat it. So that's one.
Don't use hydroxychloroquine.
Don't use hydroxychloroquine. Yeah. Don't drink bleach. That's
a good one.
Another one that's come through the weekend. Don't inject household cleaners, if you will. And I think that kind of ties in. That's probably the second one I would be, is that there is a lot of misinformation out there. It's very easy to log on, and I've seen so many self-proclaimed Facebook certified infectious disease experts. So people are going to tell you a lot of different options, a lot of different hopes, but really make sure that you're getting your information. If you're doing your research, make sure you're getting it from a reliable source. CDC is a great example of that. And then third one, I would say, I'm going to be very specific to Georgia, where I live in, that regardless of what the governor in your state says, that you are your own best advocate, if you will. So, you got to be smart and be safe. And that's, whether it's continued hand washing, whether it's continuing to wear a mask. I'll give you a good example, because I had somebody that called me about this the other week. So, if you recently had a kidney transplant, even if they open up all these restaurants, all these things, they're going, can I go back to live my life? Should I wait a while? I mean, the honest answer is if I had a kidney transplant in the past week or two, I'm probably going to hold off as long as I can and really avoid even beyond the measures that are for everybody else. And that goes back to being your best advocate for yourself. So just continue to be smart.
Yeah, and wash your hands, social distancing. I think that's the reminder for a lot of folks is this is not one mountain. It seems like it's going to be a mountain range where we're going to have a lot of peaks and valleys with this virus. So those are really great tips from you. I appreciate your time. Thank you again. I know you're working on the front line, so for even to take 30 minutes to talk with us today is very nice of you. Thank you, Dr. Jones.
All right, appreciate you having me.